Great. Hi everyone, welcome to another virtual morning report. And good morning, good afternoon, and good evening to everyone joining from different time zone. We are so happy that you guys decided to spend your time with us. My name is Hui Tin. I am an IMG from Venezuela, and today I have the pleasure to co-discuss a case with Ravi. So my first question actually for everyone is that anyone want to present today? Does anyone has a case? If not, we have a backup case, but we just wanted to see if anybody joining today want to present a case.
It's so cool to have you here. You've been part of VMR for months now, and yeah, I remember your initial messages tweeting on Twitter, and asking about CP solvers and your transition from somebody on the outside of this institution to somebody who was in the emails and doing research and um, in VMR, along with moving and citizenship and your job. I feel like you've had a very busy summer and a very impactful
Yes,
one.
yeah, exactly. Yeah, I mean, it happened so fast, so many things, but I don't know. I just feel like this is the family that I wanted to be in. I mean, I'm so grateful to everyone in this team, and yeah, I'm so glad to be able to keep participating.
It's an honor and treat. And this is the one way we try to celebrate people, like we're a bunch of global reasoning nerds and we try to honor and celebrate all the impact that people have by discussing these together. And we're really excited to do that with you today. Um, actually, I love to get to know people who've turned their video on, and I think I've met everybody, but I don't know if I've heard from Tansu. I'm sorry if I'm mispronouncing your name. Do you mind reading and telling us about yourself?
You are pronouncing my name perfectly, by the way. It is Tansu, and
Oh,
I joined the VMR recently. This is my I think fourth session with you. Um, I'm from Turkey. I graduated from medical school in Turkey and moved to New York City with my spouse last September. I'm currently doing research at Mount Sinai and applying for the match this coming year.
amazing. Welcome. It's such a thrill to have you here. I think Turkey is one of the most beautiful countries in the world. I've been there a couple times, but not really enough. And so really hope to get to see that and excited to meet somebody who spent a lot of time there, clearly. Welcome.
Thank you so much. And if you need any recommendations and you
I
plan to visit Turkey, I can give you recommendations.
love that. Yeah, definitely. I'll reach out. You guys are the um best tea hands down. It's a very controversial statement to make because I have friends from parts of the world that have very strong opinions about tea, but oh, Turkish tea is just unbelievably delicious. So thank you for that and for many other things.
Thank you so much.
Awesome. Yu-Ting, I don't think anyone is jumping at presenting a case today, so we will
So
introduce.
yes, let's introduce
Uh,
our case presenter then. I think we have this backup case, and yes, actually we have Amanda, and she is no stranger to the CB Solvers team. So Amanda is one of the leading team member for the case review committee, alongside with Omaima, and they're doing an excellent job organizing everything and allowing new member to present. And yes, if you can unmute yourself, Amanda, you can introduce yourself again, or you can just start with the case, whatever you want.
Hello, guys. Good afternoon from Brazil. And I just want to say something. If you have a case or if you want to present case, but you are shy, or if you don't know how to present this case in English, you can CC us and we can help you to formulate the case and how in explain you how to present this case in a for English format. So don't be shy. Here is a safe space. We love a new presenting case. So feel comfortable. And if you have any doubts, you can ask me after. And this is my case. It's a very shortly case, but it was very interesting to me, and I hope you enjoy. Let's start. So I will do this different. I didn't translate the case, so I will translate in the real time. Give me a look, but let's start. It's a 50 years old male and comes to the service. Remember you, I am in the family medicine practice. So it's a patient from the family medicine practice with a huge pain with intensity 8 and 10 and in the right hemithorax 6 days ago.
Hi, I think I'm gonna start probably. So yes, so we see this a male patient, 50 years old, that comes to the clinic with the chief complaint of chest pain, basically, if we will talk about. So when I think about chest pain, my framework is start to think about like some of the causes that can be life-threatening. And then once I discard those the life-threatening causes, I think we have an amazing schema on CP solvers saying to the 422, if I'm not mistaken. 4 is cardiac causes, 2 the pulmonary causes, and 2 for esophageal causes. And for the 4 cardiac causes that I want to rule out, that would be acute coronary syndrome, aortic dissection, tamponade, or Takotsubo cardiomyopathy. And for the pulmonary causes, I will try to rule out if there is a PE or pneumothorax. And for esophageal causes, I would think about rupture, impaction. And once I rule out all these like emergent causes and I say, okay, this is negative, then I can breathe a little bit and think about other causes and can be, you know, all the causes that is not emergent can be divided like superficial or visceral causes. The superficial causes, I think about maybe costochondritis, that is one of the really common cause for chest pain, or rib fracture, skin like zoster, and also think about other causes that is not specifically the heart, can be like GI causes or pulmonary causes or mediastinum causes. And this patient, because of 50 years old, I'm really concerned about like cardiac causes and pulmonary causes. I think I'm gonna pause here and see what are the thought for Rabih.
Yuting, I think that was incredibly, I can't believe those were your first contributions as a discussant. That was absolutely superb, both outlining the things you have to worry about and the things that you would then think about afterwards. And I think that's absolutely true. There's no matter what, you're going to have to exclude those two. You're going to have to visit those two spaces. And I think the interesting thing that we'll have to reflect on in the journey is what is the significance of in general, what is significance when the patient tells us that it's a very specific part of their chest that hurts? And then also, what is the significance of the pain lasting for 6 days? But I don't think anybody would really be thinking about these things right now, because what would happen right now is exactly what you said. You have to exclude to some degree of certainty the 4 + 2 + 2. But later, we can have a conversation as we navigate that journey about what is the significance when the patient says it's only on one side, and what is the significance of chest pain for 6 days. Think about that. 6 days, almost a week. Those will be interesting things to reflect on, but definitely not right now. It's more after we accomplish your goals of excluding the life-threatening causes, which you outlined so well. All right, Amanda, tell us more.
So the patient related, it's a localized pain and does not interfere with breathing and comes with paresthesia. Informs that 72 hours ago appears some vesicles in the back. Denies fever, denies trauma, shortness of breath, nausea, vomiting, and recently pneumonia.
Okay, thank you, Amanda, for giving us the HPI. And yes, actually, it's very interesting that, of course, I think Rabih mentioned already the localization of the pain that is like right side. So that make me think maybe it's a pleural effusion. And I need to know what type of pleural effusion could be. Could put something. I think there's no trauma, but it can be a spontaneous pneumothorax. And I think that you mentioned something about some vesicles, and that makes me think about maybe shingles that this patient could have. Yeah, I think that is my thought at this point. What about you, Ravi?
Yeah, no, I think you're absolutely right. So I think that that the vesicles are hard not to follow, especially given their location around the pain. Um, and I think it's really interesting to sort of step back now and say, okay, we have chest pain. We think of 4 + 2 + 2. If we slow down, Huting, what do you think it means when somebody says, oh, it's just this part? What does that signify for you?
The location that is right side. It's
Yeah,
yes, I think that is something that happens. I mean, is like I said, could be like a pleural effusion in that part. So it could be anything from like air, can be like water, can be pus, can be cells. So I will be interested to know like what the past medical history of this patient to clarify if there's anything there that can give me more clues about what is the reason of his like spontaneous hemothorax, because it doesn't say that he had any kind of trauma, a history of trauma, but I would like to know more about the medical history and see if there's correlate something with the current presentation.
absolutely right. I think that's superb. And we're getting so much closer to the diagnosis just with the physical exam that I think these kinds of cases are a great opportunity to just clarify some things that are that seem intuitive but actually are a little bit more complicated. So if we step out of this case and just talk in general, there are a lot of similarities between chest pain and shortness of breath. And if you look at the differential diagnosis of the schema for chest pain and shortness of breath, there is a lot of overlap. So why do you think they're similar? This is more a conversation. There's no right answer. This is just a cup of Turkish tea conversation, honestly. What do you think is the difference between chest pain and shortness of breath? Like, how do you approach a patient with chest pain versus a patient with shortness of breath?
Yes, I think like you said, it's very like one thing is come together. Like it's not, some patients have like dyspnea and then accompanied with chest pain. Is because like if I'm getting like shortness of breath, I feel like I'm using my muscle, just that using muscle. I'm breathing fast, trying to compensate some underlying condition. Could be anything, because when it comes to dyspnea, we approach it's very similar: cardiac causes, pulmonary causes, and within the bucket, we are very similar to the cause for chest pain. And then and of course I have to try to see what are the causes that is not cardiac pulmonary causes that is making this patient to have shortness of breath. And there could be like acidosis, can be anemia, could be musculoskeletal, even like obesity, induced hypoventilation, can be acid-based disturbances. There's so many different categories that can be like mixed in together, and it can be like, okay, we started with shortness of breath, but now we have chest pain because of that, or because we have some underlying causes that could be related to the chest pain. That's my thought.
100%. It's spot on. And if you approach it from a anatomical perspective, if somebody has chest pain, they have something from here all the way to here. Chest pain. Anything from here all the way back can hurt. The rib can hurt, the lungs can hurt, the heart can hurt, the esophagus can hurt, and the nerve can be impinged here, causing chest pain. So chest pain, basically, the schema that we have on the website is everything in the chest can hurt, but we filter out the scary causes first, as you said. And if there are no scary causes, we diagnose the benign causes. But where does shortness of breath live? In the same place, where does shortness of breath live? It lives in a much smaller space, actually. Why? Nothing here should cause shortness of breath. If I have a muscle injury, it shouldn't cause me to be short of breath. If I have a rib contusion, it shouldn't cause me to be short of breath. The presence of shortness of breath implies that the internal structures of the thorax are the problem. So if you're making a Venn diagram, the big circle is chest pain. The circle within it is shortness of breath. Shortness of breath implies failure of the cardiopulmonary apparatus to maintain homeostasis. Now, of course, that's not always true, and a small fraction of shortness of breath is from a non-cardiopulmonary cause, like you said, anemia, acidosis, but that's so small. So the general principle is anything that can cause shortness of breath can come with pain. Myocardial infarction, pulmonary embolism, pneumonia, anything that is within the failure category can cause pain. So in general, if you had to pick which patient to be more worried about, it's the patient with shortness of breath, because all of the patients with shortness of breath can have chest pain. And if they don't have chest pain, it's just sheer luck. Any presentation within dyspnea can feature pain, whatever the cause. So there's this very valuable 10,000-foot view on the difference between chest pain, shortness of breath, and hypoxemia. Chest pain is anywhere from the chest. Dyspnea is in the heart or lungs. Hypoxia is lungs. So you can see how you can localize the lesion by paying careful attention to what the patient actually has. So for now 4 years on CP Solvers, I have been saying to everybody, just like you said, chest pain must rule out the most scary causes. And if there are no scary causes, move on to the non-scary causes. But how does that happen in real life? Do you wait 1 hour for the EKG, for the X-ray, for the labs before you start to think about the non-scary causes? No. We have a clinic, we have a patient. We can't just wait for 1 hour. So how in real life do you make progress in chest pain to be more concerned or less concerned? And the answer is right here. Do they have shortness of breath? Do they have hypoxemia? Chest pain that features shortness of breath or hypoxemia immediately means the chest pain is of a sinister etiology. Chest pain that does not feature shortness of breath or hypoxemia is often benign. Most patients with an MI who have chest pain, if they walk 1 step, they will be very short of breath. Most patients with PE, if they have chest pain, if they walk, they'll be short of breath or even at rest. So if your patient says, I've had 6 days, many days to get worse, 6 days of just chest pain, without shortness of breath, without hypoxemia for 6 days, almost 1 week, the probability of a sinister cause of chest pain is exceedingly low. But you actually mentioned the exception to that rule and the kinds of things we should think about that can sneak under this detection radar. And for that, let's talk about another fireside chat, okay? What does it mean to have a chest pain on one side of the body, either left or right? What do you think that means?
I think that something is localized. Is I mean, what it is can be an infection, can be a type of mass. Well, in this case, I think about more like some kind of infection etiology, and that's only condensated in one side.
Exactly right. David is actually reflecting on this. David said in the chat, but a healthy patient can definitely present with pneumothorax or myocarditis and can just have chest pain without dyspnea. And that's the part that we have to try to understand why. So you're right. You said that when a patient says it's one side only, you know it's probably at the surface. And so why? I think the why is really important. So the why comes to understanding the different kinds of innervations that patients have. And Marino just said it. In patients who have internal organ disease, our visceral or autonomic sensation is much less well localized than the somatic nervous system, which is why when you have appendicitis initially, you have diffuse, vague periumbilical abdominal pain. But when the appendicitis progresses to peritonitis, irritating the peritoneum, overlying the appendix, the patient's like, oh, it's right here. And that's exactly what plays out here. Most patients with visceral causes of chest pain cannot tell you, they just said, my chest everywhere hurts, kind of everywhere. But if the patient's pointing in one direction, it's very likely that the chest wall is involved. And the chest wall means the muscles, the bones, the nerves. But here's the key fact. The visceral pleura makes the inside of the pleural space is part of the chest wall. And that's why the things that you were talking about earlier, irritation or diseases of the pleura, are basically the major cause to consider in patients who are presenting with persistent chest pain without progression to dyspnea or hypoxemia. It is the inside of the chest wall that brings in disorders like air in the pleural space, infection in the pleural space, or infarction of the pleural space. And the pericardium is the exact same scenario. The pericardium abuts the anterior chest wall, and pericarditis can certainly present and often presents as a pure chest pain syndrome. And so, to summarize our conversation, how does a clinician really make quick progress about life-threatening or non-life-threatening causes of chest pain? And the absence of dyspnea and hypoxemia, especially when it also includes dyspnea with exertion, really reduces the probability of visceral involvement and localizes the disease to the surface. However, the scary causes that remain at play are the diseases that exist at the intersection between inside and outside, at the intersection of the visceral organs and the chest wall, and that's the visceral pleura coating the lungs and the pericardium coating the heart. So I agree with you. The no misdiagnosis remain all of them, and we should still do the workup for them. But our pre-test probability should be low, And the things that we should really be worried about now to prioritize are, is there disease of the visceral pleura or is there disease of the pericardium? And to reflect on David's statement, I think that the pain in myocarditis alone is certainly described, but I think that it would be very, very unusual not to have myopericarditis, and the pericarditis dimension is real. So what are the pleural diseases we should entertain? Pneumothorax, infection, and infarction. So those are the things that I would definitely make sure the patient doesn't have. Any thoughts or questions about any of that, Yu-Ting? I think this is the kind of way that we can make progress without that data, and these are all pre-test hunches, but I'm curious what you think about it.
Yes, I think that what you just said is a good summary, and it brings me back to one of the academy session that you mentioned. We have 3 patients. We have one with hypoxemia, dyspnea, and chest pain. And your question is, who would you treat first? And of course, we have to treat the person who has hypoxemia because we have the objective measure that if something is wrong, it's gone. And then dyspnea, shortness of breath, that means something is more systemic. And chest pain can be anything, can be cardiac causes or can be something benign. So to reflect on that, it's great to remember what makes something more urgent, and when do we need to first stabilize the patient and then start actually doing the all the diagnostic testing, because in real life what matter is the patient. A diagnosis, I mean, we want to get to know what is the diagnosis, but we need first to treat the patient. If this patient is hemodynamically unstable, we need to do that first, and then at the same time to do all the diagnostic testing to rule out the frightening causes. We have to do like chest x-ray, that's one of the main things to do. We have to do the troponin, EKG, we have to do CBC, BMP, everything to rule out that is like a cardiac cause. And of course, when we rule out all that, like the scary causes, then we can dip deeper to the other causes.
Absolutely superb. I don't know why I'm here. That was so good. Francisco, I see you raise your hand. Do you have a question?
Yeah, I do. And actually, I remember these VMR, and I was in Kirtan's team, and I was wondering, and I was thinking about this. Is there any cause, and I'm only thinking about one, where we have hypoxemia without chest pain and dyspnea? I was thinking about intracardiac shunt. Is it besides this, are there, because it seems rare, right? Should we think about it? Yeah, Rabih, let me know.
Yeah, no, I think you can actually, when you, these are the powerful reflections that we do in real time. You can find many exceptions to all these rules that we talk about. And yes, I think intracardiac or intrapulmonary shunting is a great example of how you can have hypoxemia without chest pain. And I think you can come up with many, like methemoglobinemia is another example of you can be hypoxemia.
Yeah, I think
Also,
oh,
yeah.
sorry. No, actually, when you mentioned that, actually, I remember one of the Dr. Reza teaching point with hypoxemia and how to do. I think you mentioned as well to do a proper pulmonary examination. That is what you're looking for in a resident. Like, okay, when you walk into the round, so how is the pulmonary examination? And then if it's a normal, you can okay, you have the different causes for hypoxemia. And yes, and which one is improved with oxygen or not. So in the case, I think Francisco mentioned about shunt, and that is one of the causes that it would not improve with oxygen. So that we have to think about, okay, if it doesn't improve, could be PE, could be something else, but it is not a shunt. Okay.
Yeah, exactly right. Yeah,
Proceed.
hypoxemia thought train. I think Francisco and Huting, your question and reflection really illustrate the point that we're really talking about here, which is these conversations, especially when they're done in a didactic kind of teaching format, often carry the risk of being interpreted as factual, but all these things have performance characteristics. It's just that you should pay attention to this. The real summary of the conversation here is the following. You should pay attention to the absence of dyspnea and hypoxia in a patient with chest pain as it has diagnostic value. Is the diagnostic value perfect? No. Believe it or not, even a CT chest with contrast to look for PE is only 90% sensitive. It's not perfect. There's nothing about anything that we collect as perfect. But the longer the chest pain persists without shortness of breath or hypoxemia, here 6 days, for me, every single moment that he has not evolved to a more sinister pathology reduces the probability and really narrows it to the chest wall. So is my gaze just restricted to the chest wall? No. My gaze is open to anything, but I am ready to latch on to more and more clues that suggest this is a chest wall disease, which of course in this case includes the vesicles, but the pretest probability is now higher. And I would emphasize one thing: the chest wall also includes the inside of the chest wall. So irritation of the pleura from infection, infarction, or air, and irritation of the pericardium. Poor Amanda thought this was going to be a short case, but Amanda, please don't ever tell me you have short case. Your cases are always very, very interesting. Okay, why don't we do one more question? I think David has one, and then we'll hear the rest of the case. Okay, yeah, go ahead, David.
Just one fast question, Ravi. The one that I posted in the chat. I've asked myself before. Why does PE can cause pleuritic chest pain in the absence of pulmonary infarct? Because I don't know if there are very small pulmonary infarcts that cause that kind of pleuritic reaction and pain, but it's not uncommon to see this type of presentation in my practice. And PE can cause chest pain due to other mechanisms like right heart strain and that, but that shouldn't be pleuritic. So I don't know if you know that.
Yeah, I remember seeing your tweet, David. You all should really follow David on Twitter. He has absolutely incredible content, especially very thought-provoking questions that honestly, I don't think anybody really has ever come up with a convincing answer to many of your questions, including the mechanism of edema and cirrhosis and whatnot. And yeah, the short answer is I have no idea. I also see this very commonly and I don't have an explanation for it. I don't know if you come across an explanation or have any thoughts on it. I definitely don't.
I think I have to do my research first.
Yeah,
Please, I will.
Really good question. Thank you
Good
so much.
question. Thank you, Debbie.
All right, Amanda, you can finally talk now. It's been like an hour since we heard from you.
Woohoo, let's go. So the past medical history, the patient had hypertension. In the social history, recreative smoke and drinker, and the patient didn't treat the pneumonia correctly, the recent pneumonia correctly, and informed measles and chickenpox during the childhood, and informed that he is very anxious because of the death of his mother. I can give you the physical examination.
Please.
So the vitals. The patient has a 130% in the PP, 98 in heart rate. Temperature is febrile 37.9 degrees Celsius, SAT 93%, and on room air. Lymph nodes, it's palpable in anterior and posterior cervical regions, and in the respiratory, there is crackles in the lower right lung, and in the skin we have I don't know, I know no one, I don't want to say the skin now because it's very important and really reveal the diagnosis.
Yeah, again, yeah, actually, with the history, I mean, Amanda just told us that this patient had pneumonia but wasn't treated properly. So yes, that give me the clue that that's the cause of the hemithorax. But at the same time, this patient with the past medical history of varicella. I mean, that could be actually a reactivation for zoster, so the shingles. And this patient with infection that can trigger stress also can trigger shingles. So I think this patient, I don't want to anchor anything yet, but with the physical exam and also with the past medical history, I will incline to think about maybe this patient is presenting with reactivation of the varicella zoster. What do you think, Rabih?
Yeah, I'm impressed that you thought of that, honestly, and I think that for me, I'm in a situation that's a little bit more proximal. I'm just surprised that the oxygen saturation is low in this person, and I think it should make us rethink our position of saying he's not short of breath, but he's hypoxemic. So he broke that rule, and now all of a sudden, even though 93% doesn't really run to you, he's 50, and so he should be much higher than that, unless Amanda is now living in Mount Everest, very high up in altitude. But 93% is very, very low at sea level, because I know she goes to the beach, so she's definitely at sea level. So I'm a little worried that that small number in the top right corner, 93%, changes things. And when you see that merged with the crackles, you start to worry, oh, okay, you know what? This actually localizes all the way down to the lungs because of the hypoxemia. And so it gets interesting, this case, to think about what causes lung disease, what causes cervical lymphadenopathy, and what causes right-sided chest wall pain. And I think it's easy to say that a pleural involvement, either with an effusion, which is less likely based on the exam, with the presence of breath sounds, but pleural irritation from an adjacent alveolar process. So if I close my eyes, I think the crackles and the hypoxemia are telling me there's something in the lungs. That same side hurts. So invoking that idea that the chest wall is irritated by the presence of a pulmonary process. But I'm having a hard time connecting that with the patient having bilateral anterior and posterior cervical lymphadenopathy. I'm trying to play along with Amanda and not involve the skin yet, because we should try to make progress without that data, because that data is coming next. And so it's a really interesting case of what causes pulmonary infiltrates and cervical lymphadenopathy. And I'm curious what you think about that.
Yes, my thought about this case, I'm thinking like more could be a coexistent infection. Maybe the pneumonia who did not improve, it didn't take the antibiotic, can be now another process going on. Could be Epstein-Barr mononucleosis. That's one of the first causes for cervical lymphadenopathy. And if we think about something even worse, can be some kind of lymphoma. But I don't see anything here that can indicate me some type of malignancy yet, unless maybe Amanda give us more clues about other clinical findings. And I'm with you with the saturation oxygen is 93, is very low. And in this patient, apparently he is normal in a way. but now we have this hypoxemia. So I'm just concerned as the same way as you. Maybe there's something more happening that we're not seeing. Some kind of immunosuppression that is happening in this patient. So it's something that we need to consider. And I'm very curious to see all the other exam, if there's any, like, you know, with the CBC, if there's any infection, blood culture, chest x-ray, if we need to even do a CT scan if it's necessary. But yes, I would like to know all the other additional labs, so to think about more causes.
Absolutely superb. I have nothing to add to that. Really, really well done. Amanda, tell us more, please.
So I will share with you about the skin. 1 minute, and you said me what you think.
That's a vesicular thing, the vesicular lesion, and it following the dermatome, if I'm not mistaken. So I would like to know about the characteristic of the pain as well, because usually, like, varicella zoster come with the pain. Usually it's like burning sensation, throbbing or stabbing, and come with the rash. And usually it's vesicles, and it comes and follows a dermatome distribution. I think that is what I have. Rabih, what do you think?
No, I completely agree with you. First of all, I love the title of this, Secret Case CPS. Oh, so good. Many times when presenters have, goes to show you one of the reasons why Amanda is the co-leader of the case review committee. She has so much experience. I've been doing this for like 8-9 years now. I can't tell you the number of times the case presenter accidentally has the answer. It says, "Oh, varicella zoster mystery case," and you're like, "Oh, there you go." So you can see that she is an expert. And yeah, Hu-Ting, I completely agree with you. If you saw this, your first reflection will be that this should be zoster. The first thing I would like to point out is my observation, which may be wrong, that this is actually the patient's left side. So I don't know if, Amanda, this is your patient, or is this another image from the internet, or is it the right side? I can't tell. It's the
It's
left.
the left side. Oh my God.
I caught you. See, I'm paying attention. I'm paying attention. Anyway, so it's interesting, Hu-Ting, because look at the number of dermatomes. This is at least 2 or 3 dermatomes. This isn't just one, right? It's I don't know the dermatomes very well, but the vertical spread of this is interesting. You can have varicella zoster reactivate in 2 contiguous dermatomes without having to invoke or think hard, but it's going down all the way to the nipple line. So that's at least T4, maybe even below the nipple line, honestly. And then maybe T1 or T2, I can't tell. But you certainly would wonder whether this is much more than is expected with age-related immunosuppression. There is a differential diagnosis for zoster-form lesions that includes HSV reactivation, which does not have to be dermatomal. It includes cancers that actually metastasize on the nerves. They follow the nerve path. And the term for that is what's called zosteriform metastases. And the most notorious tumor to do that is melanoma. It hops on the nerve and actually spreads along the nerve. You can get also what's called Wolff's isotopic response. It's a very fancy way of saying that in patients who've had varicella or zoster before, they can present with a eruption of that rash from a separate independent process because the skin remembers that rash. So if you have a separate issue going on, the skin can get angry again, invoking Wolff's isotopic response. So I think I also share your reflex that this is zoster. I wonder if the dermatomes are more extensive for us to wonder if the patient has underlying immunosuppression, which you already invoked. We should wonder if the patient now who has zoster, who has pneumonia, who is only 50 years old, is too young to get all these things at the same time. So yeah, a lot of interesting things. Tell us more, Amanda, please.
So we have biopsy. We have the biopsy of the patient, but the results didn't not come out, and we start to treat the patient with acyclovir, thinking inseminated herpes zoster. And we treat the crackles as a untreated pneumonia. So we start again the treatment for pneumonia, and thinking about some immunosuppressions, we give the patient, I don't know how to say this in English, but like we send the patient for the immunologist to find any problems with immunology. And the patient comes actually on Monday, and the vesicles, it's very better 100%, and the pain that improve with the treatment, and there is no crackles, and the auscultation, it's clear. And actually you said one thing in the beginning of the reunion, Rabih. Not exactly we need to exams to give the patient diagnosis. And in the family medicine practice, we see a lot of this, like the clinical see what I am seeing, it's what they give the patient the diagnosis. So because I bring this case and I brought this case and present to you. Hope my English was clear, and hope you will like it, the case. Rui, how you feeling?
Oh, thank you. Oh my God, Amanda, this is amazing case that now I understand why you said that it's educational. So it looks like a simple case, but at the same time, it kept me thinking like, oh my God, what is that? This cannot be just shingle or a varicella zoster. I was like, oh, it has to be something more. But I think you did great job, and oh my God, you are amazing how you translate the whole case in real time. And I don't know if anybody knows, but Amanda did not have this case in English. So she was translating from Portuguese to English on the fly. So she is great. I mean, I think we have to really say a shout out to Amanda. You did a great job, and thank you so much for letting me discuss this case with Rabih. I think everybody learned something today, or a lot.
You're so eloquent, and both in your discussion of medicine and also in your ability to pass on the kindness and joy to other people. It was really nice of you to be so loving of Amanda. How did it feel for you to discuss?
I think a little bit nervous, but at the same time I feel like this is the safe place. I do suffer a little bit like yes, like public speaking. I don't like people to look at me, I think, in a way, but a little bit shy. But I knew that discussing with you, it would be great because you would like hold my hand along the way, even like virtually. So I learned so much about this case. Even the diagnosis, something simple, but the journey to reach to the diagnosis, I learned so much. We discussed so many different schemas, so many different way to approach, and there were so many great comments and thoughts in the chat. So I think this was a very nice case for me to discuss. So I feel great. Thank you.
Yeah, I would be very surprised if anyone of the audience would ever guess that you have public speaking issues. And I think maybe you can give yourself feedback on your public speaking issues by watching your video and seeing how you appear to other people. It's a little bit weird to watch your own video. I understand that, but sometimes it can give you the necessary information to not think or be so conscious about your skills, because to everybody else, you're so seamless and you flow effortlessly in a public space. So I would recommend that you watch this again. It was really cool to see. Amanda, what do you think the final diagnosis is? How are you putting this case together?
I think it's two problems. It's one problem related to the chest pain and the zoster, but we have the problem about the pneumonia. I don't know if we can say like asymptomatic pneumonia, because with no short of breath or dyspnea, but we have one patient with two diagnoses, not related the diagnosis, but two differentials.
Yeah, I agree with you. I think you can put this case together in two ways. First, you can say that he had a pneumonia, and the pneumonia created a stressful circumstance for his body, and then he had zoster reactivation. That's possible. The other scenario is you can say, well, we didn't see the pneumonia, we don't know what it is. It's also very possible that the pain from the zoster caused splinting and ineffective breathing because it hurts when he breathes, and he developed atelectasis and developed hypoxemia from the lack of aeration of his lungs. Anytime we have a patient who goes to surgery, we give them the machine to breathe in so they can keep their lungs expanded. So it might have happened that way. But either way, I think whatever diagnosis you're making, it's very unusual for a 50-year-old to have pneumonia and a 50-year-old to get zoster with this many dermatomes. And I think investigating into his immunological status is a good idea. And I'm really glad that you got that. Really, really educational. Thank you, Amanda.
Thank you, guys.
All right, Marina, take us home, please, your teaching point.
Hello, guys. What an amazing discussion. Congratulations, Huitin, and thank you, Amanda, for the really good case. So let's start. From the get-go, we got a patient that has chest pain, and I can see how many times I have emphasized this over the last few months doing the teaching points, but this should be like the 6th time I have done this. So every time we get chest pain, we need to rule out the emergent causes with the 4+2+2 mnemonic. So the 4 stands for cardiac causes, such as ACS, aortic dissection, cardiac tamponade, and Takotsubo cardiomyopathy. Then the first 2 stands for the pulmonary causes, such as pulmonary embolism and also pneumothorax. And for the esophageal causes, we have esophageal rupture and esophageal impaction. So another approach that we can take to chest pain after we have ruled out the emergent causes is to look for every structure that we have on the chest wall, on the chest, sorry. So we have the heart, so we have to look for cardiac causes, we have to look for pulmonary causes, GI causes such as the esophagus or stomach, the musculoskeletal causes, skin causes such as zoster, that was the final diagnosis, and also mediastinal causes. So in this patient, we have a really big clue since the start. The patient has had this pain for around 6 days. So that could really help us to see how was he at baseline, and also to see if, and also clinically could help us to see if, to really look out for something that was non-emergent, because we would have expected him to come earlier if he had a really emergent cause. So also from the get-go, we got that this patient had vesicles in the back, and in a patient that has vesicles in the back and also has chest pain, we can really think about zoster from the get-go. So really after this, the discussion shifted towards other problems and other pearls that we got. So one of the pearls was that the presence of shortness of breath can help us to localize pathology in the cardiopulmonary system, and also can help us to narrow a lot our differential diagnosis. Almost any presentation of shortness of breath can be accompanied by chest pain, but not most of the causes of chest pain can cause shortness of breath. So this really helped us because this patient has had this chest pain, but he really didn't have any shortness of breath. So that could really help us to like make an schema on how to approach chest pain in the outpatient, exactly. So in the outpatient, we need to look quickly for shortness of breath and hypoxemia in any patient that presents with chest pain, because that's clinically how we can rule out most of the emergent causes without performing any other studies such as EKG, an echo, or chest X-ray. So there are also scary diseases that do not fit into these rules, such as pleural and pericardial diseases. Also, another point that we talked about was how innervation can interact with and can affect how the patient presents the pain. So we have mainly two types of innervation. We have visceral innervation, and we also have somatic innervation. So when patients get problems with visceral or autonomic innervation, the pain tends to be more specific and way less localized. In contrast to patients that have somatic disease, somatic innervation problems, when you get somatic innervation problems, normally the pain is way more localized and indicates that there is a problem with the wall, either the chest wall or the abdominal wall. So many examples of this we can talk about them, but a classic example to never forget this is appendicitis. When patients present with appendicitis with the prodromal phase of anorexia, nausea, and vomiting, they have a diffuse pain that is localized mostly on the epigastrium or mesogastrium. But then after the peritoneal wall is irritated, the pain quickly localizes to the right lower quadrant. And this indicates that there is a component of somatic innervation going on. So this is the same concept behind pleural and pericardial disease causing somatic chest pain. So later in this patient, we suspected from the start that this patient had shingles because of the pneumonia and the vesicular rash. After Amanda showed us the picture, we really kind of confirmed it. So we need to think about possible causes that could reactivate shingles. This patient had chickenpox in childhood, so also a fact that was mentioned in the history is that this patient had previously had pneumonia and also was anxious because of the death of his mother. So we have mostly two causes in this patient that could reactivate the varicella zoster response, such as stress and ongoing infection of any source. So later in the physical exam, we got that this patient had crackles plus hypoxemia, and probably indicates that something is going underlying on the lungs. So we inferred that this patient didn't have correctly treated his pneumonia before. So after the patient got treatment with acyclovir, this patient really improved the lymphadenopathy, the crackles, and the hypoxemia and the rash. So another pearl that I didn't know about, I always thought of varicella zoster virus reactivation to include only one dermatome, but actually it can include more than two dermatomes, but in a contiguous fashion. So that's everything I have for you, and thank you very much.
Absolutely amazing, Marino. I think that you've done more teaching points than yogurt that I've had this month, and everybody knows that I eat a lot of yogurt, which is amazing. Thank you so much. I'm glad that you're like feel comfortable with the 4+2+2. It'll serve you handy when you're an intern after having successfully matched, which I have no doubt you will. Thank you all for an amazing Thursday. Thank you, Ting, for a fantastic discussion.
Thank you so much, everyone.
And I hope, Amanda, you inspire other people to present cases, because they will get to work with you as the leader, as the co-leader with Umaima of the case review committee. Thanks, everyone. Bye.